Hi, I'm Karen Peterson, the Vice President of Programs at the Prevent Cancer Foundation. On behalf of the Foundation, I would like to welcome you all to our third webcast of the 2020 Virtual Prevent Cancer Dialogue. We have another very exciting session for you today. Together with the American Indian Cancer Foundation, Prevent Cancer is proud to present this panel on the challenges and opportunities for cancer screening and prevention in Indian country. So to get it underway, I would like to now introduce Chris Rhodes, who is the moderator for today's panel. Chris is an enrolled member of the Bad River Band of Lake Superior, Chippewa, and she also grew up on the Fond du Lac Reservation in Minnesota. She is the Chief Executive Officer of the American Indian Cancer Foundation.
Hello, greetings, Bushu, Anin. Thank you, Karen, and I'm really excited to be here today. The American Indian Cancer Foundation is a national organization serving the 5.2 million Native people across the United States who live in the 574 tribal nations, as well as many rural and urban areas. The American Indian Cancer Foundation is focused on addressing access to quality cancer prevention, screening, treatment, and survivor support. We aim to identify and lift up solutions, build capacity, and raise awareness. Over the last 30 years, cancer mortality rates have decreased across the United States. And that is very good news for most people. However, it is not the case in Native communities. And while Native people don't necessarily have more cancer than other populations, we tend to have later stages of diagnosis of some of the most preventable and treatable cancers. So too often, a cancer diagnosis is still a death sentence in Indian country. That is why the American Indian Cancer Foundation has focused so much attention on increasing cancer prevention and screening across tribal, urban, and rural American Indian communities. We are also focused on the deep roots of health inequity, which has been much more visible in 2020. And of course, we're now seeing exactly how racism is systematic and shows up in almost every aspect of daily life, even amongst well-meaning people and institutions. The results, these inequities result in the foundation of some of the greatest inequities we see in our communities, and is the perfect condition for COVID-19 to further devastate our communities. Issues like high rates of smoking and exposure to cigarette smoke, many people living in overcrowded conditions, lack of access to testing, PPE, and or safe working conditions all contribute. So while many of us are looking forward to the end of the current pandemic, let me share that Native people are not interested in returning to that normal. That normal was not good for us, and we are looking forward to a future where tribal rights, tribal ways of being that are inherently healthy are respected and acknowledged. So at the American Indian Cancer Foundation, we know the power of partnerships and collaboration. Relationship is everything in Indian country, and our team is committed to respectful and authentic relationships with tribes, communities, and mainstream organizations like Prevent Cancer Foundation. We truly value our partnership with Prevent Cancer Foundation. That has been a decade-long partnership. And really, as we've strengthened that partnership, we've been able to increase cancer prevention and screening support to tribal and urban communities across Indian country. Of course, the American Indian Cancer Foundation or Prevent Cancer Foundation do not make things happen on our own. We grow partnerships and opportunities, and today we're excited to include a fantastic panel of speakers. I deeply respect each of these people and their commitment and actions that make our world a healthier and better place. With their leadership, we are moving toward new normal. for Native people to thrive. So we have Dr. Donald Warren, who's of Glala, Dakota. He's going to discuss the impact of Affordable Care Act on health in Indian country. Dr. Rodney Herring of the Seneca Nation will discuss clinical trials, pandemics, sovereignty, tribal governance, and community education. And then we will have the wonderful Tinka Duran of the Rosebud Sioux Tribe will discuss the program So That the People May Live, the Great Plains Colorectal Cancer Initiative. I want to say I have no conflicts of interest relevant to today's meeting. And I'm going to give you a couple of tips to make our session today go a little bit more smoother. We will wait to address any questions and comments until all presentations have concluded. The chat feature, well, it's been great to see and get to know everybody as you've signed in. It's now disabled and will be disabled during this segment. But we do want your participation and questions. So at the end of the presentations, you can use the raise hand function or the Q&A function that are both at the bottom of the screen. And we'll talk more about exactly how to do that, but we will go to raise hands first for inputs and then to Q&A for texting your questions in. Please do not use the chat feature again, because we won't be looking at it, but let's get into our presentations, starting with Dr. Don Warren.
Hello, I'm Dr. Donald Warren, and today I'll be talking about the impact of the Affordable Care Act on health in Indian country. And we'll do this within 22 minutes. It's a relatively complex discussion because we'll be looking at the Affordable Care Act, but also the American Indian health system and the disparities that we face, including cancer disparities. It's important to remember the Affordable Care Act is now 10 years old. It passed March 22nd of 2010, and this really was landmark legislation. It was an opportunity to dramatically expand access to health services for all Americans, including American Indians and Alaska Natives. So before the Affordable Care Act, we had a lot of challenges. American Indians and Alaska Natives certainly faced some of the worst health disparities in the nation, but there are significant regional differences in those health disparities. I work in the Dakotas. I'm originally from South Dakota, and I now work at the University of North Dakota. And unfortunately, our disparities in the Dakotas tend to be worse than the rest of the nation for American Indians. Much higher burden of chronic disease, including cancer, and risk factors for cancer, including commercial tobacco use. So other challenges, we did see discrimination against Americans with pre-existing conditions by the insurance companies. The premiums had more than doubled over the previous decade prior to the ACA, so it's getting more expensive and less people covered. And at the time of the passage of the ACA, there were 50 million Americans who had no insurance and tens of millions who were underinsured. So think about the Indian Health Service. It unfortunately does not have the resources needed to address the American Indian Alaska Native cancer burden. So we were dependent on what was called at one time contract health services, or now purchased and referred care. And that's when IHS has to pay for services in the private sector because we don't have the internal resources needed. So just as a very brief overview of the ACA, again, it's 10 years old. And I really look at the ACA as the largest expansion of Indian health in our generation. So there are 10 components to the law. So again, a law is something that's been enacted, a bill that becomes a law, and each chapter or component is called a title. So there are 10 titles within the Affordable Care Act. And Title I is affordable and available coverage. Title II is Medicaid and CHIP. And those are the primary areas we'll be discussing, but there's a whole host of other components of the Affordable Care Act. We won't go into detail with all of those components, except to mention that the Indian Healthcare Improvement Act was attached to the ACA. So permanent reauthorization of the Indian Healthcare Improvement Act is Section 10221. So it's in Title 10 of the Affordable Care Act. And Indian Healthcare Improvement Act allows for IHS and tribes to bill Medicare and Medicaid. It also established the urban Indian health centers and several other key components of the Indian health system. So when people talk about repealing the Affordable Care Act, they're also talking about repealing the Indian Healthcare Improvement Act. So let's briefly look at Title I and Title II. Again, Title I is affordable and available coverage, and that's been described as a three-legged stool. So you have to have insurance market reform, an individual mandate or personal responsibility to have insurance, and then premium and cost-sharing subsidies. So recognizing that not everyone can afford all of the cost sharing to get health insurance, so they established what was called exchanges or the marketplace. And I'll go into a little bit more detail in terms of what that actually means, but essentially this is an opportunity for employers and for individuals to participate in accessing health insurance at a much lower cost than what was available before the Affordable Care Act. Title II is also very important. That focuses on Medicaid and CHIP. So Medicaid is a component of the Social Security Act. And as we know, it is primarily insurance for people who are impoverished. So what they did in the Affordable Care Act through Medicaid expansion is raise the eligibility floor from 100% of federal poverty to 133% of federal poverty. And there's a significant amount of federal financing to support Medicaid expansion. Medicaid is funded by both federal and state sources. So within the Affordable Care Act, the population that receives Medicaid expansion is funded predominantly by federal sources, not by state sources. Why is this important for American Indians and Alaska Natives? Well, unfortunately, we have about 2.5 times as many American Indians and Alaska Natives as the white population who are at or below the federal poverty level. And this has been a longstanding problem going on. This is data looking over the last 15 years. We can see that the American Indian Alaska Native population has a much higher rate of poverty. So because we have an impoverished population, things like Medicaid and Medicaid expansion are vitally important to increase access to services, including services for cancer care. So over the years, we have seen most states expand Medicaid, and you can kind of see some of the regional differences here. Most of the states in the Southeast have not. There's a couple of Midwestern states that also have not expanded Medicaid. And we'll talk a little bit in this discussion today about the differences between North Dakota and South Dakota. If you're not from this region, you probably wouldn't realize that there's a big difference between North Dakota and South Dakota. But North Dakota is a Medicaid expansion state, and South Dakota is not. And that does have a big impact on access to health services. This graph shows federal expenditures for various federal healthcare programs. On the far left is Medicare spending, and you can see that that is over $13,000 per beneficiary per year. In the middle, that's the Veterans Administration. So for qualifying veterans, there's over $10,000 spent per person per year. Medicaid is at over $8,000 per person per year. For the federal employees, if you work for the federal government, you have access to federal employee health benefits. That's about $7,500 per person per year. And IHS is funded at $4,000 per person per year. So when we look at all of the federal healthcare systems, whether it's Medicare, Medicaid, veterans, or even federal employee health insurance, each of those other systems is funded at a significantly greater rate than Indian Health Service. So in Indian Health Service, we have a combination of impoverished individuals and a health system that's terribly underfunded and that has a direct impact on health disparities, including cancer disparities. So when we think about the funding for Indian Health Service, it's about $5 billion per year. And, $5 billion sounds like a lot of money until you put it into the context of the Department of Health and Human Services. So the Department of Health and Human Services budget, which houses the Indian Health Service, is actually funded at over $1 trillion per year. And you can see that the IHS budget really is a small sliver of the overall budget for HHS. So we cannot depend on just the congressional appropriation for Indian Health Service in order to have improved access to health services, including cancer care. We need to have opportunities for third-party revenue generation, including revenue generation from the marketplace and from Medicaid expansion, from the ACA, but also Medicare and other private insurance. So very briefly, let's look at the Indian health system. It's a very complex system and a very unique system. So American Indians are actually the only population in the United States that is born with a legal right to healthcare. And that's based on our treaties. We have several hundred treaties between the tribal nations and the federal government. And in exchange for land and natural resources, the federal government is responsible to provide various social services, including housing, education, and healthcare. So that's why there's a Bureau of Indian Affairs, a BIA. That's why there's a Bureau of Indian Education, the BIE, and that's why there's an Indian Health Service, the IHS. So we have to remember that Indian Health Service is not free healthcare. In truth, it's the largest prepaid health plan in history when you look at the wealth and the benefit that the United States has received from all of its natural resources that are American Indian resources. So the Indian Health Service in its current iteration was actually established in 1955, and it is an agency that's currently located in the Department of Health and Human Services. In 1975, there was a law called the Indian Self-Determination and Education Assistance Act. That's Public Law 93-638. And that law allows the tribes to take over the management of healthcare from the federal government. So that's why we now have a mixture of IHS facilities and tribal facilities, sometimes even within the same community. So we have a blend of federally operated Indian Health Service programs and tribally operated 638 programs. Well, in 1988, with the passage of the Indian Healthcare Improvement Act, that was the first time that IHS and tribes could bill Medicare and Medicaid. So we now have this very complex web of IHS programs at the federal level, 638 programs at the tribal level, and Medicaid programs at the state level. And unfortunately, with all of this complexity of multiple levels of government, different payer systems, different payment sources, we have a complex web of healthcare delivery. And as you can imagine, for something complex in terms of medical care like cancer, we have very challenging issues in front of us, and we're trying to coordinate care and services for those individuals across multiple levels of government. So how do we deal with this through the Indian Health Service? Historically, because Indian Health Service is terribly underfunded, we don't have access to all of the health services that are needed within the system. So IHS is not an insurance company. It's not health insurance, but in certain circumstances, they behave like an insurance company in that they purchase healthcare from the private sector. That used to be called contract health services. It's now called purchased and referred care. So before the Affordable Care Act, our purchased and referred care dollars ran out too soon. But now that there's additional options for health insurance under the ACA, including Medicaid expansion in the marketplace, we're able to stretch those purchased and referred care dollars to a much greater degree. So because of the ACA, that has had a direct benefit on extending the budget for purchased and referred care. So it's a huge benefit to Indian Health Service, primarily in states that expanded Medicaid. So why is this important, particularly in the area where I am from? There are now only 7 states that have at least 3% American Indian and Alaska Native populations. That's Alaska, Montana, North Dakota, South Dakota, Arizona, New Mexico, and Oklahoma. And if we look at the states ranked by American Indian and Alaska Native percentage of total Medicaid population, you can see that states like Arizona, Oklahoma, New Mexico, North Dakota, Montana, South Dakota, and Alaska, those key states, at least 10% of the Medicaid population is American Indian and Alaska Native. So we are disproportionately dependent on Medicaid, and this is even before Affordable Care Act, disproportionately dependent on Medicaid because of very high rates of poverty. So expansion of Medicaid is a huge benefit to the American Indian population. In addition to Medicaid expansion, we also had permanent reauthorization of the Indian Healthcare Improvement Act and other areas that really strengthened the Indian Health Service. So the law does increase access to affordable care for all Americans, including American Indians and Alaska Natives. And things like cancer screening, such as mammograms and colonoscopies, are now covered under the Affordable Care Act. There should be no out-of-pocket costs to individuals for those screenings. Unfortunately, because Indian Health Service is not insurance, that the no out-of-pocket costs provisions or easy access to cancer screening is not the same for American Indians. So in our purchase and referred care priorities, priority 1 is acute and urgent care, so life or limb referrals. Believe it or not, cancer screening is considered a level 2 priority. So it's we have circumstances where cancer screening is denied because the patient doesn't have insurance and they don't have enough money in the purchase and referred care budget to pay for things like mammograms and colonoscopies. So huge disparities in terms of risk for the disease, but even additional disparities based on lack of access to services. So what are some of the health outcomes of this? If we look at colorectal cancer incidence, the good news nationally is that the incidence is flattening or decreasing a little bit, but even the mortality rate is going down, generally speaking, because we've had improved processes for screening for colorectal cancer. Unfortunately, the only population in the country that is seeing a slight increase in colorectal cancer death is the American Indian Alaska Native population. And I would put forth that's not a biomedical issue, that's a health policy issue. And with less access to screening and resources for treatment, we see worse mortality rates. So people are literally dying from bad health policy. And that's why these discussions are so important. Also, it's very important to recognize that the cancer disparities are quite diverse across the American Indian and Alaska Native population. So if you look on the far right of this particular graph, for all of the United States, for American Indians and Alaska Natives in blue, actually the death rate is not that much greater than the white population when we look at the aggregated national data. But that's because in some areas, some regions of the United States, particularly the Southwest, smoking rates among American Indians are much lower. Whereas when you go to the Northern Plains, use of commercial tobacco and subsequent rate of cancer and cancer mortality are much higher. So we can't look at aggregated national data. We have to recognize that there's significant regional differences in health disparities, particularly with things like cancer. So how do we address this then using the Affordable Care Act? So as I had mentioned in Title I, the establishment of the exchanges or the marketplace was set up to offer an opportunity for purchasing health insurance. And again, the law passed in 2010 and enrollment began in October of 2013 and coverage began in January 2014. So we've now had coverage under the marketplace through the Affordable Care Act for over 6 years. So this is basically a web-based opportunity to purchase health insurance. If you've ever used Expedia.com or Orbitz.com to purchase a flight, it's a very similar process. Just like for a flight, you can decide what airline is important, what airport is important, or maybe it's only cost that you're concerned about, or time of day that you fly, for example. All of those different types of options. There's multiple types of options within the marketplace to purchase insurance through a website. The law does include subsidies, and there's basically 2 types of subsidies, and that covers the time when money is coming out of pocket. So for example, if you have health insurance, you have a premium that you pay every month. Sometimes it comes out of your paycheck if you have workplace funded insurance. So there are tax credits that help people to pay for their premiums. And other cost sharing can be the copay. So there are cost sharing subsidies as well. And for American Indians and Alaska Natives, they have set it up so there's no premiums for people up to 300% federal poverty level. It's around $70,000 a year for a family of 4. So incredible opportunities to increase access to health insurance through the cost sharing subsidies. So this really does help us out a lot. And when we think about reducing those deductibles and the out-of-pocket expenditures, we have such high rates of poverty, we don't have a lot of American Indians whose incomes are over $65,000 to $70,000. So we have a great opportunity to expand access to health insurance. Other unique components in the ACA specifically for American Indians include that we have opportunity to sign up for Marketplace at any time. There's no limited enrollment period. So as an American Indian, we can sign up for this insurance even outside the typical enrollment periods. Another opportunity, we won't go into great detail, but tribes that choose to can actually use the Marketplace to sponsor insurance for their own tribal members. And we've seen that done successfully in a few examples around the country where the tribes are actually paying for health insurance through the Marketplace. So what does that mean for us here in North Dakota? When we think about different levels of income, the key numbers are 138% federal poverty for access to Medicaid expansion, and between 138 and 300% federal poverty looking at access to the Marketplace. So Medicaid and Medicaid expansion, Marketplace with no cost sharing, and then if you're over 300% federal poverty, most of those people are already insured, but there are some who have that high income but don't have insurance. For American Indians here in North Dakota, we estimated it's about 60% of the population is at or below 138% poverty. Another 30% are up to 300% federal poverty. So 90% of our population is eligible for insurance at no cost out of pocket. And if the tribes choose to, they can actually, through Public Law 93-638, take over those purchased and referred care funds and pay the cost sharing to ensure that everyone gets insured. And one of the outcomes here in North Dakota is that our insurance rates have increased dramatically. So I did publish some information on Affordable Care Act just recently in Health Affairs, and here's some of the data. So for American Indians and Alaska Natives who have access to Indian Health Service, we can see that the number of people without any insurance has decreased significantly, particularly since 2013. So implementation of Affordable Care Act has decreased the uninsured rate for American Indians and Alaska Natives who use IHS. For American Indians and Alaska Natives who do not use Indian Health Service, you can see the green bars that the access to private insurance has gone up significantly. So these are just wonderful opportunities for more American Indians and Alaska Natives to have access to insurance. Here, if we look at the Great Plains area, the orange bars are American Indian, Alaska Native, and the blue bars are for the white population. We can see that the percent change for American Indians has gone up significantly since the Affordable Care Act. So much more health insurance right here in the Great Plains area because of the Affordable Care Act. If we look specifically at public insurance, so not the Marketplace, but things like Medicaid expansion, you can see dramatic increases in access to health insurance because of the ACA. That has a huge impact on access to cancer screening and treatment. In addition to Medicaid expansion, utilization of Marketplace for private insurance has also gone up significantly. So in the Great Plains region, North Dakota, South Dakota, Nebraska, and Iowa, we've seen significant increases. But it really is mainly in North Dakota. So if we look at South Dakota, the uninsured rate between 2012 and 2017 was unchanged. No changes in South Dakota. But if we look at North Dakota, the uninsured rate fell from 35% to 25%. And that's simply because of expansion of Medicaid. North Dakota expanded Medicaid, South Dakota did not. And as a result, we see dramatic differences and disparities based on those political decisions at the state level. So I know that's a lot of information in a relatively brief period of time, but I hope that gives you a good overview of the Affordable Care Act, the Indian health system, and how those programs work together to address screening and treatment for all kinds of issues, including cancer. Thank you very much.
Hello, my name is Rodney Herring. I'm Seneca from the Beaver Clan, from the Cattaraugus territory of the Seneca Nation of Indians located in Western New York. And that's about 30 miles south of Buffalo, New York, just on the edge of Southern Ontario and Canada. Today I'll be sharing perspectives on clinical trials, pandemics, and sovereignty tribal governance and community education in relation to prevention, intervention, cancer, things of that nature that are co-occurring in our communities. I believe this is going to be an excellent parallel to some of the information that that has been presented during today's webinar. Also kind of intertwining some of the public health type issues and concerns and resiliencies, the colorectal screening parallels that occur both in Indigenous communities and non-Indigenous communities and what that means to Native American populations. I'm from Roswell Park Comprehensive Cancer Center and the Center for Indigenous Cancer Research. First, I would like to share a story. I like to start off with stories that kind of give a perspective to Indigenous thoughts and philosophies and the things that perhaps have connection to our communities. And this story comes from Indigenous and Indigenous population, perhaps not in the Americas, but I think it has some parallels to some of the ideologies and issues and things that are relevant to our communities. And also kind of indigenized, it's kind of a Haudenosaunee or Iroquois or Seneca picture to it too. So you'll see here that there's a beaver swimming across this waters or lake or a pond or a river. And you also see a fish jumping in the air here. And so the first part of this story kind of surrounds around beavers, and many people are not aware that beavers are vegetarian. And so and they also use wood not only as their primary staple of life for their food source, but they also use it for building their dams and other structures around their homes. And so in this story, it starts out by the beaver really looking for something to eat, looking for something to build its dam and structure and build a homeland and really create a safe space, but more so looking at really improving and finding a good source of food. And across this stream, across this river, the beaver noted that there was an abundance of healthy foods, an abundance of building structure, and it really needed to get across because on the side it was currently on, there was kind of a lack of that resource. The beaver also noticed that the water was very turbulent, it was very strong, the current was very strong, and it looked to be a challenge to cross. However, the beaver, being a great swimmer, decided, well, I'm going to take that chance to cross that stream, to go across and collect some of this wood for food and for building materials. So as the beaver decided to cross the river, again, the current was very turbulent, it was very strong, and the beaver had a really hard time crossing that river. And at one point, it went under and was spun around in the rapids and disorientated, and it was very exhausted. So when it finally reached the other side of the river, other side of the stream, it kind of landed on shore and really was exhausted to the point that it needed to take a short break, and it fell asleep. It was so exhausted. Upon awakening from this short rest and looking around, the beaver noticed that there were fish kind of jumping out of the water in this little eddy on the side of the stream, on the side of the river, where the current had slowed down, but there was just a little piece of area that was kind of still and tranquil. And so the beaver gathered itself and started walking towards the edge of the water, and there was a branch hanging over the side of the stream. So the beaver went over to the top of the branch, and beavers have digits, kind of like humans in a way, and started grabbing these fish that were jumping out of the water, reaching up and grabbing a vine and tying each fish to the vine. And in the beaver's mindset, because it had just crossed this river and it was very turbulent and it had a very challenging time, and it was, in some essence, almost close to death because it got turned around. It was had a really hard time then. And the beaver's mindset that it was reaching out and saving these fish, all these fish, by tying them to this vine. And ultimately the fish would die because fish, of course, need to be in the water to survive. So in the beaver's mindset, it was saving the fish in its own culture of thinking that, with the best intentions, that it's saving each fish one by one. But in reality, it was not making the right choice, because what the fish were doing were actually jumping out of the water and eating insects as their staple of life. So we see this parallel in some of these animal stories and stories of what we learned from our environment and our animal relations, that, what is right and correct in one population, in this case, beaver population, and its way of thinking and being having the best interest for its relations and communities that it sits parallel to, may not be the best choice or best process or best intervention for, in this case, a fish population. So different types of things occur in our communities. And I think that parallels a lot to when you see the interventions that we're doing in Indigenous communities, or research, or screening, what is sometimes with the best intentions for one community doesn't always translate into other communities. So we need to be aware of that. And this story is it teaches a good story about awareness and being self-aware in the work that we do. So now I'm going to transition into pandemics. Indigenous populations have been impacted by a variety of diseases and epidemics over the centuries, have resulted in thousands of deaths and the extinction of some tribes, actually. Indigenous populations were not previously exposed to most diseases introduced by Europeans. Population really had built up an individual or population immunity to these diseases. And you'll hear about some of the epidemics and pandemics over time. And Indigenous populations often surround around smallpox and measles. But if you also look in more contemporary times, you'll see this in some of the influenza, the SARS, and some of these other pandemics that have affected not only populations worldwide, but also Indigenous populations. And it's really challenging and hard to really look at what that means for Indigenous communities. And if you look at the coronavirus or the COVID-19, which is currently happening at this time, that you'll see that Indigenous populations have faced some of the greatest challenges with assessment, with intervention, and also with the talk of research of doing corona or COVID-19 type trials or research in communities. And how does that parallel with some of our other things that we're working in our communities? How does that parallel with our need to continue cancer screenings, for example, prevention? And what does that mean, and how has that changed since that time? So we're at an interesting time here, and all of these things are very important to our communities. And so this is an excellent way to kind of open that discussion and understanding and awareness of perhaps the differences that are occurring. There are different types of trials or investigations. Prevention trials involve tests to find ways to prevent a particular medical condition. And the emphasis of these studies might be related to medicines, screening, intervention techniques, lifestyle changes. Intervention trials or treatment trials are research projects that set out to test treatments that have not been officially approved. For example, a new drug which is believed that would be effective for the treatment of cancer. There are therapeutic trials, and there are ones in which the treatment under investigation is believed to be likely to be, helpful in a way that to benefit the participation in some way. Non-therapeutic trials is one which is unlikely to produce any direct benefit to the participants involved. And the aim of a non-therapeutic trial is to obtain knowledge which may contribute towards the future development of new forms of treatments or procedures. So this kind of gives you a breakdown of the different types of trials that occur. And I'll be referring to all of them, but when we think about trials too, these are in research, these are kind of the things that are happening out there. And for this particular presentation, I'll be focusing a little more on the prevention trial side. What is the importance of these trials? Indigenous populations face some of the greatest cancer health disparities, and also list co-occurring conditions. Because when we think about cancer, when we think about not only in Indigenous communities, but all communities and all peoples, that cancer doesn't always happen by itself. In Indigenous communities and other communities, there's something else going on with the individual. For our communities, sometimes it can be related to diabetes or obesity or heart disease. And so although we're looking at ways to prevent cancer, We also have to be aware of the co-occurring conditions that are happening at the same time and treat an array or look at an array of different things. So that's one very important aspect of knowing and understanding. The participation increases the chance that intervention such as cancer prevention or screening trials are effective and translatable to and for Indigenous peoples, meaning that oftentimes that research is sometimes conducted with populations that don't always include a strong base of other peoples. Because Indigenous peoples are usually a smaller population, and even more so than other racially or ethnic communities, that we get left out in a number of cases. But it's really important that we're part of these clinical trials or understand what that means for our communities, because if a certain prevention, intervention, or technique or assessment or pharmaceutical advancement is conducted or through research, those findings are sometimes maybe only applicable to a certain population. If it's not tested with other populations, we don't know if it's as effective or efficient or works together to help those people that are perhaps in a smaller population. So it's really important to encourage and understand, I would say more so understand what that means for Indigenous people, especially during pandemic times. But we also have to be understanding that, it's really not, what is the benefit to the community? And that was really the kind of the goal of research too, and it was a population in the Indigenous context, is what is the benefit to the nation? So we have to really look at that. Bring awareness of the diversity in operational and administrative structures amongst Native nations and how to work with tribes or consortia of nations is vital. We also have to not only understand that the importance and perhaps the benefit of certain types of research in our communities. And again, looking at prevention and those layers of different types of research. Some tribes may have interest in one type of research over another, but we also have to understand the structure of that tribe and the administrative capacity of that nation. There are over 570 federally recognized Native nations in the United States, and over 500 bands in Canada as well. So if we look in North America, there's well over 1,000 Indigenous sovereign nations. And so what does that mean? It means that, there are some nations that are really larger and have a larger capacity for things. Administratively, and for example, writing for a grant or a research grant and then implementing it, where other nations are perhaps smaller and don't have as much administrative infrastructure. So we have to really be aware of the diversity and operation of administrative structures. One for research, but also for implementation of cancer screening, prevention initiatives. And so what does that mean? How do we work with nations and with a good mind and moving things forward for the benefit of the communities? And part of that, and we're going into the next bullet here, with the educating community members after tribal approval about clinical trial process important. So one is the benefit of the community, and this is usually engaged with the tribal government presenting a proposal at a macro level and receiving permission to either do the research or a quality improvement project or prevention, intervention, whatever it may be. But it's also important after approval that the projects work in the communities to educate about, in this case, clinical trial process. So although we may have permission to go into a nation to do research or screening or whatever it may be, it's also very important to educate every community member and those that have interest about what research is, what screening can be, and what does it mean in an Indigenous context. And we remember our story about how the beaver crossed and the parallels between the beaver and the fish in the two different populations. How do we translate indigenize some of the cultural nuances to doing screening and research in Indigenous communities? And part of that is working with families. Part of that is understanding historical context. Part of that is working with the tribal leaders to really kind of indigenize that process of screening or research. And so during pandemics, this is also very important to understand because tribes and researchers need to be aware of the potential coercion of, when a pandemic occurs, such as the COVID-19, that the treatment and testing is a great need for our communities, but it can also be tied into, kind of the area of coercion, at least in relation to research, and what is the benefit to the community. So nations are often weighing what that benefit is to the nation and to the research that may be occurring. During emergency and pandemic responses, tribes must be consulted and research projects must be honored with the CBPR, or community-based participatory research process. That means that it's not expedited, tribes are not pressured to get into research, but are allowed to have the full tribal review. And our projects incorporating Native peoples into the projects through their tribal employment rights ordinances at the respective nations are the projects empowering the nations to take lead on the projects, have sovereignty over the process, and really be engaged in that process. Our projects looking at any potential tribal grievances procedures, and are there any licensing fees that the nations are implementing for specific research projects, for example. There's also a good conversation about the consideration of intellectual property and compensation, especially for Indigenous knowledge that leads to Western scientific advancements. Robust data sharing agreements and profit sharing have commercialized. So many times you'll see in the history of Native peoples and Indigenous populations from around the world that it's really important to look at that, how some of the Indigenous knowledge is not only in prevention or intervention or screening, but in some of the products and medicines and traditional medicines that Native people have used over time and have now become part of Western medicine. And so this, it's a really important area to really understand and be part of. So these are all part of that full tribal CBPR process and full tribal review to really look at some of these things and how they can be incorporated into research protocols, and honoring and respecting nation-to-nation governance and sovereignty, including incorporation of the United Nations Declaration on the Rights of Indigenous Peoples when and where applicable. And I also showcase some of our work that we've produced in this short media clip here called Translating the Interplay of Indigenous Knowledge in Modern Medicine. And it really ties in some of what I've been talking about, both in a research context, but more so in an intervention context and a traditional medicine context. What does it mean for Indigenous knowledge to interplay with modern medicine and modern intervention and modern screening techniques? So this short video, I'm not going to play it here, but I'm going to provide the link here, and it's a YouTube link that really kind of showcases that interplay and what that means. So moving forward, we talk, here the title of this slide is Post-Pandemic Research. And what does that mean? That means research and thoughts and ideologies that move beyond our current state of what our world is in with this pandemic. What does that mean for cancer prevention? What does that mean for screening? What does that mean for research? And where does our attention move beyond when this pandemic starts to resolve or become more, we understand more of our next step and next chapter? And so the way we think about that in a Haudenosaunee or Iroquois philosophy is that we think about in the 7 generations forward. And here you'll see my 2 beautiful daughters, and our younger generation those are the things that we are working toward. Those are the young leaders that we are working towards, making our younger generation healthy, sustaining and continuing our population and mindset on things. So in Haudenosaunee philosophy, we're always looking forward 7 generations. The actions and the things that we do today, and what does that mean in the well-being and well mindset of our 7 generations forward. So when we look at those beautiful faces there, we look at our children and we look at how do we move things forward. Research is part of that. Screening is part of that. Intervention is part of that. Prevention is part of that. Those are all things that we should not only be looking at our current snapshot of things or a research project that lasts a day or two, or a research project that goes, a short period of time. We should be looking 7 generations ahead and what that means for our future leaders. So prevention research, at this time we're looking at prevention, we're perhaps looking at what's happening with this pandemic, but we also have to look at some of the things that may be occurring after this happens. What is the next steps for looking at perhaps some of the substance use issues that may occur after the post-pandemic? What does that mean for healthy eating? Has our eating patterns changed over time during this pandemic response? Has tobacco use decreased or increased? What are our mental health concerns in relation to what's going on today? So those are all things that are part of this co-occurring mindset. How do we change? How do we improve? How do we indigenize some of our prevention type techniques and mechanisms? Is it moving forward and including a virtual component in everything that we do for a short time? Perhaps. But what does it mean beyond that? We also need to look beyond the U.S. to global Indigenous populations and reviewing some of the successful pandemic prevention interventions and how they may be translated, implemented, or disseminated in our communities. I know the Maori from New Zealand's had a response to the pandemic that has been seen as pretty resilient. And what can we learn from other Indigenous populations worldwide and translate to our people here? And finally, building a sustainable CBPR or community-based participatory research or relationship or however you see CBPR plans beyond our emergency or pandemic related response. We want to make sure that we're working with Indigenous communities. It isn't just for a short period of time. When we engage with a government, a Native government, or a Native health department or a community, we want to make sure it isn't just a piece of time, that we continue this engagement over time in a sustainable fashion for the health of people generations forward. So again, this post-pandemic and the research and the intervention and all the things that we're kind of tying together, we really need to take into consideration how that moves forward generations in the future. And so, I'm very appreciative to be asked to share on today's panel. I believe that what I've shared will complement what others have shared or are going to share. And, I think this is great. I think this is very informative, and we are very thankful to be part of this conversation. If you have any questions, I'll be on this call or to answer any questions after. But also, if you would like to reach out to me in the future, I'm sharing some of my contact information here. Thank you. Nyawi.
Opetu Washday. Good day. My name is Tinka Duran, and I'm Chichangu Lakota, an enrolled member of the Rosebud Sioux Tribe. I'm the Prevention Programs Director under the Great Plains Tribal Chairman's Health Board. Underneath that umbrella is our Colorectal Cancer Screening Initiative, GPCCSI. So the Great Plains Tribal Chairman's Health Board was established in 1986. It's an organization representing the tribal communities in the 4-state region of South Dakota, North Dakota, Nebraska, and Iowa. Our mission is to provide quality public health support and healthcare advocacy to the tribal nations of the Great Plains by utilizing effective and credible or culturally credible approaches. So who do we serve? We serve 17 tribes and 1 service unit in the Great Plains region, again, of North Dakota, South Dakota, Nebraska, and Iowa. We have over 200,000 persons in their region that self-identify as American Indians. Our main health system partner that we work with is Indian Health Service. The Indian Health Service is an agency within the Department of Health and Human Services. It's responsible for providing federal health services to American Indians and Alaska Natives. The IHS is what we call it for short instead of Indian Health Service. IHS is the principal federal health care provider and health advocate for Indian people, and its goal is to raise their health status to the highest possible level. the IHS provides a comprehensive health service delivery system for approximately 2.6 American Indians and Alaska Natives who belong to over 574 federally recognized tribes in about 37 states. The provision of health services to members of federally recognized tribes grew out of the special government-to-government relationship between the federal government and the Indian tribes. This relationship was established back in 1787 and is based on Article 1, Section 8 of the Constitution. So our tribal health care and Indian Health Service facility partners are listed here. There are 20 of them in the Great Plains region and includes one urban facility. So is colorectal cancer common among American Indians? Yes, it is. It's the third most common cancer for Great Plains American Indians. It occurs more often in Great Plains American Indian tribes than other whites and American Indians in other regions of the U.S., except for Alaska Natives. And most are diagnosed with colorectal cancer at later stage of disease when it's harder to treat. Most likely is to affect American Indian men and women over the age of 50. We have seen early onset, which early onset means is the people are getting diagnosed at younger ages. So let's talk a little bit about our screening rates and target rates. So GPRA, which stands for the Government Performance and Results Act, measures IHS screening rates. It's a standardized performance measure, and it provides a way to assess how effectively IHS provides these screening services and allows them to track their performances from year to year. We do know there's data reporting issues with GPRA, and we've worked very hard with our facilities to provide technical assistance on increasing accurate reporting into GPRA. If you look at the national target rate, it is set pretty low at 32.6. And then our area pretty much reached it, 31.9 or 32%. Again, we work with our facilities to really try and go over that goal because it is a low goal, target rate goal. So we've worked with our facilities to try and increase those. We've seen many of our facilities increase by 50% or more. So we're excited to know that we're able to help them with that. So let's talk a little bit about evidence-based interventions. We call them EBIs, and they're treatments that have been proven effective through outcome evaluation. And it really is a way to increase our screening rates in our tribal areas. We use the community guide on how we implement these strategies. There are 4 evidence-based interventions. There's patient reminders, provider assessment and feedback, and reducing structural barriers. And there are also 3 supporting strategies, and that's patient navigation, small media, and community clinical linkages. So in terms of community clinical linkages, we facilitate community clinical linkages with our target outreach to our communities and clinics by assessment and evaluation, community engagement, individual and community education, skill building, and promotion. We also provide subawards to our Great Plains tribal partners by the use of community grants. Through these subawards, tribal communities provide evidence-based intervention approaches to encourage screening to eligible adults, and we provide tools and resources, project evaluation, awareness, media campaigns to assist them with their subawards and their projects that they're doing. One of the things that we've found useful is what we call Roland colon and Nolan colon. The larger one that you see here is a walk-through colon model. It's inflatable and you can walk through it. And the smaller one is also one that you can walk through, but it's for use in smaller type, maybe smaller clinics where the big, larger colon, walk-through colon would not be able to fit. So we partner with our subawards and our tribal partners, and at each of these events, they're required to have a nurse or provider there to hand out stool kits or screening kits to those that are eligible. The Rowan colon is a great visual tool that includes pre and post testing on it. So before they go in, we have a short assessment, knowledge assessment, and then when they come out at the end, we ask them the same set of questions. And if you look on the larger colon there picture, you can see placards, and those have the answers to the questions. I think there's 2, 4, 6 of them. So it's a really great educational tool that the community members kind of laugh and giggle a little bit as they go through, but we've seen a huge increase in learning and understanding of colorectal cancer and screening. In 2018, for instance, the facilities were able to screen approximately 2,000 additional persons in partnership with us. This number doesn't include other screenings that took place within those clinics. In terms of small media, we assist tribal communities with educational material for mailing, emailing, social media, and other media types. We know printing can be expensive, especially color printing, so we're able to assist them with that as well. We've also made some other educational materials, some infographics. The first one is how to complete a FIT kit. The second one is what is a colonoscopy. The third one is 7 steps to completing a colonoscopy. We know a lot of people are very worried when they have to complete a colonoscopy, what's it going to be like, what happens, and this really tells them exactly step by step what to expect. We also developed posters that we've created posters that include local persons that have been affected by colorectal cancer, and we distribute these out into our communities. They hang them in their healthcare facilities. It's a great way for persons to go, oh, hey, that person looks like me. We know that sometimes material needs to be developed that looks like our community members, because otherwise they may think, that don't look like me. That's, that doesn't affect me. That's not part of me. So we've really been able to put people in our posters, and they've been happy to share them and had great success with those. We also developed digital stories. These digital stories are on our website, and people can comment on them, and the person tells their cancer journey or their cancer story. Those have been very effective as well. We also have a PSA, a public service announcement, that we have developed that's being shown in all tribal and IHS healthcare facility waiting rooms. We have many more videos and survivor stories. Here's just one example.
How's it going over there? I used to just come in here for my daily download and never thought much of it. Then, one day, blood. Right there, staring back at me like the red eyes of a brown snake. Scared the, out of me. Good thing I was already empty. So I went to the doctor right away, and you know what he said?
What did he say?
He said, you better get a colonoscopy. And I said, a clone's copy? Why would I want to clone that? But he said, no, a colonoscopy. It's when they take a little camera up there to see what the heck is going on. It's not a big deal. It's way smaller than what just came out of me. Anyway, I bent over right there like I was tying my shoes. But I guess that's not how they do it. So I scheduled an appointment to come back. Thing is, I couldn't eat the day before, and I had to drink a concoction that really cleared my pipes. I guess what they're looking for is called polyps. Looks like a little prairie dog in there just poking his head out. Those little guys can make trouble, even turn to cancer.
Did it hurt?
Nope, you're sleeping the whole time. He snipped a couple polyps out and said there was only one they needed to check for cancer. Everything came back clear, but now I get it done whenever the doc says to. I don't need any trouble when I'm dropping logs, if you know what I mean.
I hear you, bro.
Doc says catching polyps early saves thousands of lives every year. Too bad not everyone gets the old colon inspected. There's another test they got called the FIT test, or as I like to call it, the bag it and tag it. You just collect a little at home and send it in to get analyzed. You don't have to send the whole thing. Learned that the hard way.
Man, I should really do that.
Right on, brother. Too much?
Yeah, cross the line, bro.
If you're between 50 to 75 or have a family history of colon cancer, talk to your healthcare provider about a colorectal cancer screening. At-home test kits like the FIT or FOBT tests are available. Screenings save lives.
So again, that video, we've seen high success with that. We play it in our Great Plains region's IHS and tribal healthcare facility. They have monitors in there, TVs, and usually you see the news or something. That video and others are being played in those waiting rooms, and we've heard back from people saying, "Oh, we've seen that video; it's really funny." And sometimes humor is the best way to get to people, so we've had some good enjoyment with that. The other thing that we've done is tribal proclamations. And what those are is we have the tribal president or the tribal chairman or chairperson sign a resolution that encourages or to proclaim March as Colorectal Cancer Awareness Month. These tribal proclamations have been effective in increasing community awareness. We place them in newspapers, we put them on radio ads and social media outlets. Our tribal leaders are looked up to, and if they're signing an official resolution, people pay attention to that. So we're excited about those. I wanted to talk about the medicine wheel. The medicine wheel has been used by generations of various Native American tribes for health and healing. It embodies the 4 directions, all which symbolizes dimensions of health and wellness and the cycles of life. Each of the 4 directions, west, north, east, and south, are typically represented by a distinctive color and usually are black, red, yellow, and white. And they also represent our aspects of health, our mental, our physical, our emotional, and our spiritual. And many of our tribal communities recognize this, and a lot of our elders, which especially with colorectal is where we focus, use this as a way of life. So it's important that we understand that and incorporate these into our educational material, into our program as a whole. We do understand there are some cultural challenges. We need to make sure, like we said earlier, that we develop educational and resource materials with American Indian persons in it, so people recognize it. It's role modeling and the community education. We want to ensure that educational material includes local role models, elders, and others in our community education. We have some that believe that if you talk about cancer, you can bring that cancer on. So it's really important that we talk with others and we talk with our elders, like Mr. Rhodes here, and you see in this picture, he's from our Standing Rock tribal nation, and he knows that it's okay to talk about it, that you can talk about colorectal cancer or whatever cancer it is, and that it's okay, it's not going to bring it on, and it's important to talk about it and get screened for our tribal communities, for our health, for our people. And one of the things that we also say is so that the people may live. Sometimes screening for yourself is not an effective messaging for our people. Screening for our community is an effective message for our people so that our people may live. So it's really important to know that you focus on the community when we do our education and not the person, because it's not as effective to focus on the person for screening, if that makes sense. We also need to ensure that we, with oncologists and other medical staff that are treating American Indians, that they understand that there may be cultural traditions that they need to be aware of. There needs to be, there's a need for Western and traditional integration. Traditional medicine and cultural practices need to be discussed and included in the cancer treatment if that person so chooses to do so. So it's important to many of our tribal members diagnosed with cancer to reach out to their traditional healers for healing and treatment. And we need to understand that and make sure that we don't exclude traditional medicine with Western medicine. So really, for the best interests of our patients and family, that our medicine people and our oncologists work together. I do want to talk a little bit about evaluation. It's an important aspect of our program. We provide trainings and technical assistance to our tribal communities on evaluation. We track our trainings and our events. We collect feedback at events. We gather feedback from our subawards, and we provide templates for our subawards to report their annual progress. We also developed a toolkit, an evaluation toolkit that's specific to our Great Plains Colorectal Cancer Screening Initiative program, its priorities, and its work. It's got tools in it. It's basically an evaluation toolkit that has many different tools for the clinics and for the tribal communities to use. One of the things that we talked about earlier was the provider assessment and feedback. And this is a tool that assists with deciding how to assess a health system screening practices. It looks at the practice of individual providers or a group of providers. It compares their performance to national standards or overall clinic screening rates. It collects data by reviewing electronic health records or medical charts. It presents the data in an easy to understand graphic or report. It summarizes the results to the clinic as a whole, or it can be, again, for individual providers. These findings can be used to improve clinic practices and develop a plan to raise their screening rates. So within that provider assessment and feedback, we developed a checklist for increased screening. So we use the American Cancer Society. They have two books that they have. One is How to Increase CRC Screening Rates and Practices, and the other one is Steps to Increase Colorectal Cancer Screening Rates, a manual for community health centers. So we developed this checklist that's hyperlinked from both of those guides, and we go through it with the clinic staff. We've had tremendous success with this toolkit. It's really, instead of flipping through books, it's all hyperlinked. It comes up and you can figure out exactly if you want to talk about screening rates or policies, different policies, determining an individual policy risk level. You can click on that link and it'll bring up that page from those two books, and you can go over and assess, is it fully in progress, is it in progress, or not yet in progress? And we take notes and we ask them about, assess where they're at with that, and they talk about it, and sometimes they decide, hey, this would be great to implement into our clinic, or, we might need to adapt it a little bit to implement it, or that's just not going to work, because not everything works in every clinic the same. So, for example, one of the things that we use that we've seen a lot of success with is the algorithm that they have. We can take this algorithm and they can adjust it to their specific clinic. And I've seen many of the clinics take this algorithm, put their information in it, and blow it up into a poster and put it in the nurses' stations. So the nurses have it there to look at and to follow along. It's been very successful. So some preliminary program evaluation is our videos. They've said that we did some surveys with our Subawards, and 95% of them said that they're very culturally relevant. They tied the health to cultural importance in Native communities. It's intergenerational connection. We also have a conference, and we've been able to educate them on strategies to increase screening. Over 100% said it was, a great way to for them to learn how to increase screening in their clinics. So some take-home points that I want you to be, I want you guys to know about is reducing structural barriers can modify your environments and support healthy choices across the population rather than just on an individual level. Social media and other supporting strategies need to be culturally relevant to reach your intended audience if you're working in Indian country. And you need to understand and address the community cultural beliefs. And what works in one community may not work in the other. I know two communities that are across the river from each other, and what works in one community definitely does not work in the other. So it's really working within the community and making sure that you're working with them. So just want to introduce, this is my grandma and my grandfather. We call them Lala. And I do this for them. This is why I do the work that I do. And if there's any questions, I think we're saving them for the end. But I thank you very much. Here's my contact information. If you should have any questions, please feel free to reach out to me. Thank you. Wopila.
Great presentations, everyone. I am looking forward to this panel discussion, and I have so many questions, but I'm here to really hear from the audience. And so here's how the audience can participate. The chat feature is disabled again, so don't use the chat. If you want to ask your question live, use the raise hand feature located at the bottom of your screen, and we will come to you first. If you want to text your question, please do put that in the Q&A box, and we will get to those questions after the raised hands. So one way or another, we'll get to all the questions. And I am going to start out with a question for Dr. Warren. Dawn, thank you for your presentation. I always learn so much from you, and thank you for explaining that complex issue. And always you leave us with a key phrase to remember, and this new one I got today is American Indians have the largest prepaid health plan in history when given the tremendous value of the resources that were exchanged. And yet we know the reality is our systems are underfunded. How can the everyday person or any of us on this call participate and move forward to really support the policy systems that need to be changed to impact Indian country?
Yeah, well, first, just want to say thanks to Tinka and Rodney for their wonderful presentations and to be a part of this panel with you as well, Chris. In terms of advocacy and helping out, I look at kind of in three different arenas. One is in public health and social advocacy, another is politically, and another is financially. In terms of public health and social advocacy, one of our challenges is that we're not always included in the discussions or in the data sets. So there's wonderful social movements like Black Lives Matter, and I believe in those movements. But in truth, in many cases, the Indigenous data are even worse, and we're not included in those discussions. So I think just increasing awareness that our disparities are across the board, not just in health, but also in social arenas, and please be inclusive of Indigenous peoples in those discussions. From a political perspective, we don't have federally recognized tribes in every state. So we have 14 or 15 states that have no tribes. So we're at a huge political disadvantage. And for those who are involved in political arenas or pay attention to such issues, we need tribal issues to be put on political agendas, even from political representatives that are not from the states that have tribes or a lot of tribes. And in terms of financially, you know, we do have the National Indian Health Board. They're a nonprofit organization and a website at nihb.org. And we have a network of regional tribal health boards that are also nonprofit entities, including the Great Plains Tribal Chairman's Health Board, where Tinka Duran works and where I used to work as well. And they're always in need of resources. These are nonprofit organizations, so even tax-deductible donations to National Indian Health Board or the regional health boards can go a long way toward helping out. And unfortunately, I can't stay for the entire Q&A session. I just wanted to say thanks to everyone for having me included.
Thanks so much, Dawn. Dawn's gone. It's up to you too. Rodney, it was really great to hear your presentation as well, and I really appreciate how you start out with a story. You always start out with a story that gets us thinking and translating the data and to indigenize that. And I'd really like to hear some more about how that cultural awareness, how does that cultural awareness translate into clinical trials when it comes to, like, you're a Native person running an Indigenous organization within an academic institution, or non-Native huge academic institution, Roswell Park. Can you talk a little bit about how that works? What works in that situation? I guess let's keep it brief.
Yeah, well, like Dawn, I'm very appreciative to talk to you and be part and to see Dawn and Chris and Tinka. I believe we've met in passing, but it's great to have such a great conversation of, what we call in our Haudenosaunee or Iroquois philosophies, this bringing together of good minds that we're all working towards thinking, good things and putting all our minds together as one to kind of come out with a really productive and outcome for our communities. Part of that is the way we, interact with our peers and our institutions and our academics, and how we interact in our communities, and how do we carry forth that good mind type of thinking in all that we do, in the projects that we are conceptualizing, in the interactions we have with our academic and research peers, the relationships that we have, whether it's a nation institution to federal government, or individual researcher to federal government, whatever it may be. How do we carry that for a good mind forward? And it's really about education, I think. And you'll hear that now, especially with the things that are occurring in our world, that we're in this constant state of diversity education. And for many of us, it's been a part of who we are, being a smaller population of academic or scientists in our respective institutions, not only now, but going through the education process ourselves. And what is that, and you'll hear that terminology of diversity fatigue. I don't know if you've heard that yet, but it's kind of like, we had to play not only a role of creating science by the direction of our communities, or intervention, or being part, community-based process with our communities, but on the other side too, we're constantly educating our institutions, which is a good thing. But we really need to, forums like this are really important, because that's part of that process. We're providing education kind of from the community. Many of us are community researchers or community practitioners, or, we may work in the city, or we may work off territory, but many of us go home afterwards. We live on the reservation. And so we were in these multiple roles and mindsets of how to really bring this all together. And it's really a collection of not just indigenizing outward, but it's really working together to really kind of combine multiple mindsets for the wellness of all peoples. And if we look back at some of our early wampums, which are they're kind of contracts or stories in Haudenosaunee, and it really portrays some of these early thinkings between people that first came to the Americas, and the first point of contact here in the East are these wampum treaties or wampum belts. And the one that is really significant at this time, I think, is called the two-row wampum, which talks about that we'll travel together as an Indigenous people and non-Indigenous people in a parallel path. And that we try not to get into each other's canoes, so to say, but we work together in a parallel path for wellness and for working together, and that we're respectful of the path, and that we don't forget about the other canoe. We don't forget about the Indigenous people, or we don't forget about the non-Indigenous people, that we try to work together for learning together for the wellness of all people.
Thank you for sharing that. It's very helpful. And Tinka, thank you. It was so good to see you. Your presentation is awesome. It's really exciting to see how the colorectal cancer initiative has evolved into something that's making a huge difference with many tribes across the Northern Plains. I'm wondering if you could share a little bit about what would an organization or an individual that wants to work with a tribe on cancer screening and prevention, how would they approach that or start that process?
So that's a good question. I think in terms of Rodney's presentation is probably more adept at answering this, but definitely CBPR, Community-Based Participatory Action Research, which is a mouthful to say, so we call it CBPR. But it's really important that you, if there's programs or organizations that want to work with a tribe or a tribal organization, that they reach out to them and work with them individually. It's also important to invest in the community. It sounds like I'm having connectivity issues again. Welcome to living out in the country. But anyways, it's really important that we invest in the communities. If there's, like, for instance, research projects, it's important to think about hiring from within the communities. It's also important that they go through, if there's a tribal IRB or the nearest American Indian or IHS IRB board to make sure that what they're doing is appropriate. Knowing that the data is owned by the tribe is also important. When people like to publish data or and then even to publish the stuff needs to be approved by the tribe. So there's definitely some big differences between working in tribal communities versus non-tribal communities in terms of data, in terms of community involvement, and understanding the cultural and of the communities is also very important as well.
Thank you, Tinka.
You're welcome.
Can you also talk about, a question came in about what will be the major modalities used for colorectal cancer screening in the Northern Plains? Oh, you're muted.
Whoops,
There you
sorry.
go.
So, sure. Many of our facilities across Indian country, across the United States, are not able to do colonoscopies in their hospitals or their clinics. So, majority of the Great Plains region uses the FIT kits or the FOBT kits to do stool testing. And then if it comes back positive, then it moves from screening to diagnosis. And then they move on to a colonoscopy from there.
Thank you. Rodney, I have a question for you. Came in. It says, Rodney, do you personally know other researchers who find it difficult to recruit engagement in clinical trials due to mistrust of the medical community? And if so, how do you overcome this barrier?
That's a good question. I think that's a historical question too. Like I think research in Indian country is in the timeline of research across the world is fairly new in the sense of ethical research, meaning that, I think there was research done over time. It's just that tribes may not have been a part of that process. And so we're actually in a timeline of history of research of the Indigenous people. We're kind of at the forefront in creating this new space of understanding. And it's really about respect and understanding that, it's nation to nation to university or nation to nation to research institute. And it's this kind of triad of understanding. The real challenging part for many institutions is they're really, one is to build that trust and gain that trust. And to do that, it's imperative to have Native people that are trained in that process hired at the institutions. And so if an institution is seeking to work in Indian country, what better way to gain trust than to hire or promote an Indigenous researcher to be part of their staff or faculty, and to really create a space that is indigenized from not only from the community to the institution, but from the institution back into the community. And it may start by encouraging youth to be part of the institution's academic summer research programs, for example, to create a cadre or a cohort of future aspiring scientists. It really starts there with our kids. And ultimately, that's how you engage and be part of that process of science. It has to start now. And we really have to engage our youth. We have to engage institutions and universities to hire more Native scientists, outreach workers, and programs like they did here at Roswell Park, where we're building out the Center for Indigenous Cancer Research. But on top of that, part two is that, that we're not looking just to go in and do research at a one-time thing. It's a continual process of engaging over time with multiple tribal administrations. Just like every kind of government in the world, their leaders change, so do tribal government leaders. So we have to really engage across the whole continuum of process of working with our community, and not just elected leaders, but community leaders and traditional leaders, and that we engage the entire community and process with a vision of sustainability. And that's really the key, is to hire within our communities, encourage our youth to become scientists, and engage the sustainable partnership over time.
I love it. I love how your answers, both of your answers, are always about thinking those generations back and those generations ahead. That's where we're going to get to our long-term solutions. The questions are rolling in. I think some quick ones here. Tinka, are there resources for breast cancer screening efforts similar to what you shared for your CRC initiative?
There sure is. We have another program for our breast and cervical cancer early detection program, and it's called Honor Every Woman. And I can pull up the, you can go to our Great Plains Tribal Chairman's Health Board website and look under programs and look for Honor Every Woman. I also will pull it up here in just a minute and put it in the chat box.
Fantastic, thank you. And of course, the American Indian Cancer Foundation also has a number of great resources that are culturally specific for tribes. So I invite you to visit AmericanIndianCancer.org. And Tika, can you elaborate a little bit more on structural barriers? That's always a tricky one, but it makes so much sense once you know what it is, right?
Yeah, it is. So structural barriers for us is really, a lot of ours is seeing, like, transportation is a structural barrier. We know that in our large communities, there is very rural. If the weather's bad, if it's snowing or if it's raining, many of our people may live down farther into a hill and it's not a paved road. Many of them may not even be gravel roads. So they're not able to get out of their homes to get to a screening event per se. So it's really trying to look at those types of barriers that are affecting people to get screened. We know, like I said, we've looked at working with other facilities, possibly providing gas cards for transportation. They may not have a vehicle to get to the screening event. Holding a screening event on a Saturday instead of during the work week, where maybe more people can attend. So those are some of the things that we've really tried to do.
Thank you so much. Really exciting stuff, and we could keep on going. Actually, we get to keep on going. After a break from the sponsor, there's going to be a discussion, a live discussion, a peer-to-peer discussion. So big thanks to our speakers. You all were fantastic. And I'm sending my big germ-free hugs your way of appreciation. I want to say Nyawe to Rodney, Palamiea, to you, Tinka, and Don, and Miigwech. Thank you to everybody. So again, stay tuned for the presentation and an opportunity to have a real live discussion. The amazing Melissa Buffalo is going to join us, and then we will have this peer-to-peer information session where we'll talk about updates on cancer screening and prevention programs in Indian country, and especially in the times of COVID-19, and concluding the webcast with a poster presentation with some interesting projects to talk about cancer prevention, early detection in rural populations. So again, I can't say enough. Thank you both. And stay tuned for a word from our sponsor.